Hi, my name's Emma France. I work at the University of Stirling, and with my colleague Ruth Jepson from the University of Edinburgh, I've put together these training materials on qualitative evidence synthesis and meta-ethnography for beginners, for people taking part in the emerge project as advisors and participants. What is qualitative evidence synthesis? Well, to explain what it is, it's helpful to think about the parable of the blind men trying to describe an elephant. On feeling the trunk, one proclaims it to be rather like a snake, while on feeling the ear, another explains it's more like a fan. Yet another man, on touching the legs, describes the beast as tree-like, and so on. Each man describes the elephant differently depending on which part of the animal's body he's touching. If you want to know what the whole elephant really looks like, you have to merge all the men's descriptions. Similarly, if you want to find out what's known about people's experiences of a particular healthcare topic, for instance, their experiences of having type 2 diabetes, then you could look at individual qualitative studies, each of which will give you a picture of a certain group of people with diabetes in a certain setting or country. But to get a bigger, more complete picture of experiences of diabetes, you need to bring together a range of qualitative studies. In a qualitative evidence synthesis, the researcher identifies qualitative studies in a particular topic and pulls together or synthesises their findings. So similar to the elephant parable, merging or synthesising the findings of individual studies, qualitative studies on a topic, can enable us to gain a richer, more comprehensive understanding of a phenomenon or health issue compared to any single study on its own. Other terms you might hear for qualitative evidence synthesis are qualitative synthesis, meta-synthesis, or sometimes they're called qualitative systematic reviews. There are lots of different types of methods or approaches for qualitative evidence synthesis, and some are shown here. Researchers have identified around 20 different methods, many with similar but slightly different names, as you can see there. All qualitative evidence syntheses aim to draw together the findings from a number of qualitative studies that focus on a specific topic, like people's experiences of having rheumatoid arthritis, as I was just explaining. But some approaches just summarise or aggregate what existing studies find. Other approaches, like meta-ethnography, reanalyse and reinterpret existing studies. There's been academic debate about the pros and cons of synthesising findings from qualitative studies, but these kinds of syntheses are becoming increasingly common and accepted. For example, they've been used to inform National Institute of Health and Clinical Excellence clinical guidelines. They're also called NICE for short, and they've been used to influence healthcare policy. The most commonly used qualitative evidence synthesis approach in health-related research is meta-ethnography, and many qualitative synthesis approaches are based on meta-ethnography. So just moving on, what is a meta-ethnography? Well, it's an approach that was developed in the 1980s by two academics, George W. Noblet and Dwight Hare, who were working in the USA in education research. They designed the approach to help policymakers understand why racial desegregation in schools in the Midwest of America was not a success. A qualitative evidence synthesis that had summarised the common findings and mostly ignored the differences from 5 large studies couldn't fully explain to policymakers why desegregation had not been successful. They needed a synthesis approach that would interpret the findings from the different studies and take into account the different contexts or cultures of the different schools studied. Noblet and Hare described the process of a meta-ethnography as making a whole into something more than the parts alone imply, that is, going beyond the findings of any individual study. Meta-ethnography was originally designed to synthesize a type of study called an ethnography, which is reflected in its name, meta-ethnography. Ethnography is a collection of qualitative methods used in the social sciences that generate a detailed description and interpretation of a cultural or social group or institution such as a school. And since it was developed, meta-ethnography has been used to synthesize other types of qualitative studies, not just ethnographies. Noble and Hare described 7 phases in doing a meta-ethnography. You can see them here, and I'll go through them. But in practice, these 7 phases overlap, they can run in parallel, and you can go backwards and forwards between them, so it's an iterative process. Phase 1, called Getting Started, involves deciding the focus of the synthesis, that is, the topic. So for example, experiences of chronic pain, and the research question that you want to answer. So for example, what are people's experiences of living with and being treated for chronic pain? Phase 2, which is called Deciding what is relevant to the initial interest, is the process of identifying and selecting qualitative studies to include in the synthesis. And there are different ways of going about this. Some researchers believe that you should try to identify and include every relevant study in your topic. Other researchers say this isn't necessary and you can be more selective about which studies you include in the synthesis. Phase 3 is called Reading the Studies, and unsurprisingly, this involves repeatedly reading the studies, but it's more than that. It's also about noting down the findings, specifically noting down what are called the metaphors, concepts or themes. So a metaphor or concept is an explanatory idea, and themes are patterns across data sets that are important to the research question you're asking. I'll just refer to concepts from now on for all those 3 terms. So phases 4 and 6 come next. They're the most complicated and difficult to understand in a meta-ethnography. Different researchers doing meta-ethnographies have gone about doing these phases in various ways, and they've sometimes had a different understanding of what the phases are and how they're defined. And there's quite a bit of technical language or jargon to deal with, and there'll be more on that shortly to explain it. So phase 4 is called Determining how the studies are related. And in this phase, you look at a list of concepts that you've got from phase 3, and you ask, are the qualitative studies or their concepts about similar or different aspects of the topic? Do their findings support or contradict one another? The answers to these questions then influence how you go about synthesizing the studies. Phase 5 is called Translating the Studies into one another. This kind of translation is different from translating one language into another, such as French into English. Translation, according to how Noble and Hare see it, is about systematically comparing the meaning of the concepts in the different studies, taking account of the different study contexts, so for example, where and when they were done and with whom. And the researcher is trying to identify any common concepts. So the researcher asks him or herself questions such as, are the concepts in one study similar in meaning to those of another study? Do the concepts in the studies contradict or refute one another? Do the studies identify different aspects of the topic under study that can be drawn together in a new interpretation? The result of the translation process is seen as one level or type of synthesis in a meta-ethnography, and this process is considered key to meta-ethnography and is said to be what makes it different from other qualitative evidence synthesis approaches. And I'll give an example of phase 5 shortly. Phase 6 is called Synthesizing Translations. The idea is that if there are many common or translated concepts from phase 5, these can be further compared with one another to see if some concepts can encompass those from other studies to reach new interpretations and understandings. But exactly how to do phase 6 wasn't described in detail by Noble and Hare. I'll give you some examples of how researchers have done phases 5 and 6 shortly. In reality, phases 5 and 6 tend to happen at the same time rather than one after the other. The final phase there, phase 7, expressing the synthesis, is about tailoring communication of the findings of the meta-ethnography to the audience, so for example report writing, and this could involve making messages clear for policymakers or clinicians, for example. So before we move on to an example of a meta-ethnography, here's a bit of important jargon about phase 5. You'll probably hear people talking about these different terms in the emerge meetings, so it's worth knowing what they are. So there are 3 possible types of synthesis depending on how the qualitative studies are related. The first one you can see there is reciprocal translation. Next is refutational translation, and the third is a line of argument synthesis, and I'll explain what these are. In brief, Noble and Hare described reciprocal translation, which you would do in phase 5, as being used when the concepts in one study can incorporate those of another because they're very similar in meaning. For example, imagine that study 1 has concepts capital X and capital Y. Study 2 has similar concepts labelled small x and small y, but it also has a new concept, small z, that isn't in study 1. Study 3 also has concepts y and z, similar to those in study 1 and 2, but it also has a new concept w that doesn't appear in either of the other two studies. So there is overlap between the study concepts, and you could do a reciprocal translation. Noble and Hare said that refutational translation is used when the concepts in different qualitative studies contradict or refute one another. For example, looking at this slide, if study 1 found that chronic pain is life-changing, but study 2 found that it isn't life-changing, while study 3 found that chronic pain is imagined, the concepts are too different to be able to do the reciprocal translation. These studies are contradicting one another, and you would have to carry out a refutational translation. And finally, the third type of synthesis, a line of argument synthesis, Noble and Hare describe as when the qualitative studies are identifying different aspects of the topic that can be drawn together in a new interpretation. For example, if one study is looking at experiences of being diagnosed with a condition, such as cancer, and study 2 is looking at people's experiences of cancer treatment, getting treated, and the third study looks at people's experiences of recovering after treatment. So they're actually all looking at very different aspects of the same health condition. So you would do a line of argument synthesis. Since Noble and Hare's book came out, some researchers doing meta-ethnographies have suggested that you can actually have all three kinds of synthesis in one meta-ethnography. So you could have reciprocal and refutational translation and produce a line of argument synthesis in one meta-ethnography. For example, if the qualitative studies that you're trying to synthesize contain both similar, or reciprocal, and contradictory, refutational concepts, and the studies also cover different aspects of the topic, you could do all three kinds. So in phase 6, the overall aim of a meta-ethnography is to produce new interpretations. And in phase 6 there are at least 3 levels of interpretation. First, which you can see there, is how the research participants interpreted their own experiences of, for example, a health service or health condition as the experiences have been reported in a published study. Second level is how the researcher who's carried out the study, maybe interviewed the participants, how the researcher interprets what the participant has said. And then third, you've got how the researcher doing the meta-ethnography, the meta-ethnographer, if you like, interprets what the researcher has said in their published study. If you recognise the meta-ethnographer at the bottom left, you get extra brownie points. Yes, it is Professor George Noble, who we saw earlier. To take the analogy of journalism, these 3 levels of interpretation are a bit like the difference between what the person who is interviewed by a journalist says, the first level, what the journalist understands from this and then writes up in an article, which is a bit like the second level, and finally what the reader of the newspaper article then understands from what was written, which is a bit like what the meta-ethnographer is doing. Some people doing meta-ethnographies have used the terms first, second and third order constructs to describe these 3 different levels of interpretation, as you can see there. Not everyone thinks this is a good idea, and some people find it confusing or unhelpful, saying it can be difficult to tell the difference sometimes between first and second order constructs in a published study. Next, I'm going to show you an example of a meta-ethnography to illustrate the ideas and points I've covered so far, looking at phases 1 to 7 of a meta-ethnography and how they've been done. So this is a healthcare example of a meta-ethnography about lay meanings of medicines, and I've adapted it from a meta-ethnography carried out by Pandora Pound, Rona Campbell and colleagues, and they did a meta-ethnography to answer the question, the research question, how do the perceived meanings of medicines affect patients' medicine-taking behaviour and communication with health professionals? So that was their phase 1. They had their topic focus and they had their research question. The next step, phase 2, they identified published qualitative studies which might relate to their research question on experiences of medicines, and they selected studies which would help them to answer their research question, and they included four studies in one of the early versions of their meta-ethnography. In phase 3, they read the studies in detail repeatedly and listed and described in detail the concepts from each study. And for illustration, I've just called the concepts A, B, C, etc. to give you an idea of what they did. And you can see there that they listed the label of every concept and next to a detailed description that was contained in the published study. In phase 4, Pound and colleagues determined how the studies and their concepts were similar or different. So they were comparing the concepts in the different papers, and it became clear to them that the studies didn't contradict one another, even when a particular concept wasn't identified in a particular paper. The relationships between the studies appeared to be reciprocal about similar things, so they could do a reciprocal translation. And you can just see in the graphic that there was overlap between the studies and how they kind of overlapped. In phase 5, Pound, Campbell and colleagues created a grid or a table to lay out the concepts from the studies they'd included in their meta-ethnography. This was to help them to do phase 5, translating concepts from one study to another. And I've adapted and simplified their table here. So they looked for common and recurring concepts in the 4 studies, and they identified 6 of these, which you can see in column 1 of the table. So these concepts were adherence or compliance, such as not taking your medicine as prescribed, self-regulation, for instance adjusting the dose, aversion, such as being afraid of side effects or addiction to the medicine, alternative coping strategies, such as using alternative therapies instead of medicines, sanctions, such as feeling coerced into taking medicine, either by family members or health professionals, and selective disclosure, so for example, people not telling their doctor that they had altered the dose of their medication. Not all of the 4 studies contained every one of these concepts, and the ticks just show which concepts appeared in which studies. So this figure shows the 6 concepts from the 4 studies. These were reinterpreted by the researchers doing the meta-ethnography to come up with 4 new interpretations. Again, I've simplified what they did. So from the 6 concepts that we saw earlier, these were their new interpretations. I'll just give you a moment to read them. And the arrows show which of the concepts from the 6 concepts from the studies fed into which of the new interpretations of the team of researchers doing the meta-ethnography. So Pound and colleagues state that their interpretations, their new interpretations, were still consistent with the original findings, but that they also extended beyond them. So they gave a bigger picture than any single study alone had done. And the researchers went on to describe how their 4 new interpretations related to one another, and they called this explanation a line of argument. Other researchers might call it a model or a theory. And the researchers concluded that people resist taking prescribed medicines for chronic conditions because of concerns about the medicines rather than due to failures in doctor-patient communication or patient failings to take medication as prescribed. And this was an important new finding that indicated that trying to increase medication adherence by changing patient behaviour or enhancing clinical communication would be a waste of NHS resources. It also found that patients' priorities and concerns about medicines differed from those of clinicians and had actually been neglected. And they recommended that future research should focus on testing the effectiveness of alternative treatments and improving the appropriateness of medication, such as helping to design medication that had fewer side effects. So Pandora Pound and colleagues wrote up their findings in academic journal articles, a report and book chapters. And the findings of the meta-ethnography informed a clinical guideline on medication adherence. And it was a nice clinical guideline. And here is a quote from the guideline, the NICE Guideline Development Group. They had discussed the appropriate kind of research that would provide evidence of patients' actual medicine taking behaviour. And they considered that the Pound synthesis provided the type of evidence they were looking for. The description of patient behaviours and factors influencing patients' medicine-taking behaviours were used to inform the recommendations about exploring patients' beliefs and concerns, the type of information that patients may require, and to describe common medicine-taking behaviour that health practitioners might wish to discuss with patients. So as this example of a meta-ethnography shows, well-conducted, well-reported meta-ethnographies can provide valuable evidence to improve patient experiences, public health and health services for any health condition or topic or service. I'd like to thank you for listening. I hope you learned something from the presentation and that you have a much better idea of what a meta-ethnography is and how you might do one, and I hope you've enjoyed listening to it.